right. Hello. Welcome to another edition of OrthoCarolina's monthly webinar series. My name is Michael Paloski, and I'll be talking about pediatric scoliosis. This is being live streamed on our Facebook, Instagram, and YouTube accounts. And please do not hesitate to ask any questions in the comments, and I will try to address them all at the end. As I said, my name is Dr. Michael Paloski. I'm one of the pediatric orthopedic surgeons here at OrthoCarolina in Charlotte. And one of my specialties is spine and spinal deformity. And so I'm going to spend some time tonight going over pediatric scoliosis. I'll talk a little bit about it and then leave time for questions at the end. So without further ado, let's get our slides up and get things rolling here. So our main pediatric center here in Charlotte and Randolph Road, our website is below. Feel free to contact and reach out to us. But briefly talking about scoliosis, so what is it? So scoliosis is curvature of the spine in the coronal plane, meaning how you see things from the front, more than 10 degrees. So we all have a little bit of curve in our spine. More than 10 degrees of curve is classified as scoliosis. We measure that as called the Cobb angle. And that is the angle of degree of the curvature. And as we see in this picture here, that nice straight spine on the left, so there's no scoliosis there. And then you see those curved spines on the right with those kids with scoliosis. So how is it classified? So there's a lot of different ways to get curves in your spine. Idiopathic is the most common, and I'll go over these in a little bit more detail. There's also congenital scoliosis, neuromuscular scoliosis, and many others. But the most common ones we see here in the Pediatric and Adolescent Center is idiopathic, congenital, and neuromuscular scoliosis. So congenital scoliosis, what does that mean? So that's scoliosis caused by a deformity due to the vertebra, the bones of the spine. So as they're being formed, usually in the belly, that sometimes we get a wedge-shaped vertebra or a misshapen vertebra that causes the spine to curve. And it doesn't always mean that congenital means babies. We could find congenital scoliosis like in this picture in this x-ray in an adult who had an extra little vertebra in the lower spine there causing that scoliosis. And it's different from infantile scoliosis or neuromuscular scoliosis that we'll see in young babies. A lot of times this can be seen and diagnosed in infants as well, but it's a little different from the others, and I'll go into that a little bit more. Another common type of scoliosis we see here in the pediatric department is what's called neuromuscular scoliosis. And this scoliosis is a deformity due to muscular imbalance, or how those muscles pull on the spine and on the vertebra themselves. Sometimes these muscles can be too tight and cause the spine to curve, and sometimes the muscles can be too loose and the spine doesn't have any support, and so it causes it to curve. And the kids that tend to have neuromuscular scoliosis we'll see are ones that have cerebral palsy or spina bifida. Now, the most common type of scoliosis in general, and the most common we see here in the clinic is what's called idiopathic scoliosis. And that's where we have normal spine anatomy and normal spinal cord anatomy, but the spine curves. And like I said, by far, this is what we see the most. Typically, majority comes on in adolescence, meaning around your early teenage years. And we really don't know what the true cause of it is. We think it's most likely genetic, but there can be other factors that we're looking into, that there's research going on here in 2023, almost 2024, trying to figure out, is there something else besides genetics? Because as we look at kids, even identical twins that have scoliosis, identical twins have identical DNA. And although they may have both scoliosis, their curves can be shaped differently. I have patients like that in my office where they're identical twins. They both have scoliosis, but they have different shaped curves. So if it's truly 100% genetic and in DNA, then they would have identical scoliosis and identical shaped curves, but they don't. So we think there's something else going on. We're still trying to figure that out with the research that we do here at OrthoCarolina, and even across the world for scoliosis these days. So how do we classify idiopathic scoliosis? And we usually classify this by age. So when scoliosis is diagnosed between the age of birth and 3 years old, we consider that infantile scoliosis. When it's diagnosed when the child is between the age of 4 and 9 years old, we consider that juvenile scoliosis. And when it's diagnosed from 10 to 18, we consider that adolescent scoliosis. And the infantile and juvenile scoliosis grouped together is referred to as early onset scoliosis, because there's little different things that we have to keep in mind when treating these kids, because they are still growing, their spine is growing, their ribs are growing, everything that's attached to that spine is still growing. So it has a lot of growing. So we have to keep that in mind. We have some different tactics for the early onset scoliosis groups as compared to the adolescent scoliosis groups. So how is idiopathic scoliosis treated? Well, it depends. It depends upon the age of the patient, like I talked about earlier, whether it's early onset scoliosis or if the patient is more skeletally mature, is closer to being done growing. It's also treated based off of the degree of curvature, or how big is the curve. So just in general, if we look at kind of Cobb angles or that degree of curvature, even in younger children in early onset scoliosis and adolescents, just a kind of a broad overview, typically scoliosis that has under 20 degrees, 25 degrees of curvature, we observe, we watch, we see what the spine is going to do. Is it going to get better and improve as the child grows? Is it going to get worse? Cobb angles that are around 25 to 45 degrees that don't have much growth remaining. In other words, they're nearly skeletally mature. These are our kind of 14, 15, 16-year-olds. We still observe those too. We follow these kids for a few successive x-rays to see if this scoliosis will worsen or will stay the same, and then get a better idea off of that. Now, kids that have scoliosis that have growth remaining with Cobb angles around 25 to 45 degrees. So these are kids at risk for the spine to progress, because as kids grow taller, curves tend to get bigger. So if we have growth remaining and we're already kind of in this risky range of 25 to 40, 45 degrees, those are kids that will often brace and or add in some physical therapy to help try externally to prevent the progression of this scoliosis to needing surgery. Because once we start getting Cobb angles and curvature over about 45 degrees, that's when we start to consider surgical intervention for the spine. So when I say observe, it's not that we just sit back and do nothing typically. So we'll recommend exercise, recommend even some physical therapy if kids are having back pain that's associated with their scoliosis. If these kids are overweight, weight loss is definitely encouraged. Any extra stress on the spine, taking that off can help as well, both with pain as well as progression of the curve. Diet, is there things they could or should be eating? And then we'll check x-rays about every 6 months. So 4 to 6 months, we come back into the clinic, we get x-rays, and we plot data. We plot the age of the child, the degree of curvature, how much they're growing. And we kind of look at this on a graph and see is the curve getting bigger and bigger and bigger as they get older, or is it kind of plateauing and staying the same? And that kind of helps determine next steps for us. So when we talk about bracing as well. So these are kids that have curves around 25 to 40-ish degrees. It's not an exact set number. So if we're in the range, but we have a discussion together of what the steps are, and the child still has growth remaining, typically about more than 2 years of growth remaining, we can recommend a brace, a scoliosis brace. And you can see some of the pictures there. I have a brace here, a nice brace. So it's foam and plastic. And these are pretty standard here. Some braces are made of different materials. Some are 3D printed these days, but they all do the same thing. They act externally to help push on the spine. And some braces we wear just at night, and some braces we have for the kids that wear full time. And there's a lot of different types of brace out there, but the end goal is actually kind of push on the spine and guide it as it is still growing. Think of it like a tree. If you have a little sapling that's growing, you put stakes in the ground You can guide that tree to grow nice and straight. And so these are our kids that we put in a brace, our little saplings. But you have big old oak trees that are 2 feet, 3 feet around. And you try putting braces on or stakes in the ground, and you're not going to change the way that that tree is growing. And those are the kids that are older that really can't brace. So we want to brace these kids that still have growing remaining to hopefully guide them, slow down progression of their curve while they grow. So the curve may still progress wearing a brace, but we want to try and at least slow it down so it's not getting to that surgical threshold. And so if we do get to the surgical threshold, what does that involve? And the gold standard here in Charlotte and across the world even is what we call a posterior spinal fusion and rod. So it's a surgery. It takes a few hours. We perform them here in Charlotte on a very consistent basis. We're a high volume center. Uh, and we take these instruments and put them on the spine, help straighten it out, and then hold them there. And then the body heals over these rods, and those rods stay with the kids forever. And the goal of the surgery is to stop that curve from getting bigger, number one, and also to improve that spinal deformity, to help balance out the ribs, balance the shoulders, balance the spine, the discs above and below, helping to keep things very symmetric, as symmetry is important. And that, like I said, is the standard of care, and that's what has been the standard surgical treatment with these pedicle screws, little anchors, and rods for about the past 30 years. Now, kids that are still growing, there's some other different surgeries that we have to consider. So, the kids that are still growing, sometimes we use expandable rods. So, there's pictures here of these rods where they have little anchors at the top and bottom, and they stretch and stretch and stretch, and we can actually control the growing of the rods through a little machine that we have here in the office that will stretch these rods a few millimeters every month and growing with the kids as they grow, so that we're not fusing anything as they're growing, as their spine's growing, as their lungs, as their chest is developing as well too. There's another thing that we could do surgically called vertebral body tethering or vertebral tethering. And this is also done for patients that have growth remaining. So what we do is we try and capture that growth and reverse it. So we'll, through a camera, through a scope, put these little anchors on the convex side or the curved side of the spine and hold a rope, that's really a strong rope that goes into those little anchors. And so we do is we tether that convex side. So as the child keeps growing, the convex side, the big curved side, is held tethered, and the inside, the concave side, still grows. And as you see in this picture here, as the child and adolescent grows, that the curve can improve itself on its own. Although this takes time, this is another option for children and adolescents that are still growing. And as you see, kind of the indications here, Cobb angles around 30 to 65 degrees with flexible curves and not a lot of rib rotation because this really only corrects the spinal deformity just in that frontal or coronal plane. There's also what's called minimally invasive deformity correction, an even newer surgical technique coming out that uses one rod on the concave side. There's a little stricter criteria. So these last vertebral tethering and the minimally invasive deformity correction types of corrections are newer. They're much more stringent. They are both FDA approved. We do perform these surgeries here in Charlotte, but there is a smaller window of kids and patients that are good candidates for this type of procedure. But just to know, there are other options out there besides the gold standard posterior spinal fusion if the patients meet these criteria. So that's about 15 minutes that I've been talking about pediatric scoliosis. So this leaves us a few minutes to answer any questions that any listeners, viewers may have out there. So we'll carry on here and let's see what we have here. All right. So, all right. Question. We found out my daughter had mild scoliosis last year from MRI. Since being involved in high school volleyball, she has begun to have lower back pain. So could this be from her scoliosis? Great question. So is there pain associated with scoliosis? If you read the doctor books on scoliosis, they say scoliosis isn't painful. And what that means is as the spine curves, you're not going to feel, kids don't feel the spine curving and say, man, my spine really hurt today. My curve must have gone up 10 degrees. However, as the spine does have a curve in it, and sometimes as these muscles get asymmetric because of the scoliosis, it can put strain on the back right where the curve is, or even in other places. So, you know, it's not always 100% of the time that the scoliosis causes the pain, but there probably is some causative connection between the two. So, typically when I see kids like this that have scoliosis, you can't always blame the scoliosis, but the best way to treat that, that lower back pain, and typically is stretching, doing some kind of core exercise, because even if it is the scoliosis can be affecting it, it's usually a muscle imbalance cause of pain. So stretching, core exercises, sometimes topical analgesics like your aspirin, biofreeze, heat to that low back area, and even like a massage and working with a chiropractor too can be helpful. But if you notice that it's not getting better just with kind of those activities, and even sometimes backing off of volleyball, which could be the hardest thing to do for the kids, and if it's still persisting, then that's when having one of us check her out and see, is there anything else going on that can be affecting. Another question. What is recommended for a severe scoliosis for a child age 2? No other issues at the moment. So another great question. So at age 2, that's much, much younger on the spectrum than we typically see. Usually these kids that present with scoliosis are teenagers. So this falls into that infantile scoliosis group. So first, we want to know, is there another cause of it? Is it congenital? Is there a vertebra that's causing it? Is there something going on in the spinal cord that's causing it, or is it truly idiopathic? And in kids that are very young, if it is idiopathic, in other words, they have a curve of their spine, is it genetic? Is it something of that nature? Things that we could do are casting. So sometimes putting on a cast, the children go to sleep and we put a cast around their body and kind of mold that, or a bracing even as well too for a child age 2. And some of those surgical options, you really want to wait as long as you can, but sometimes casting or bracing can be done at age 2 to help slow down progression, or at least get the kids old enough where they can have one of those other growing type of implants placed in if needed. Another question. What are typical recommendations for mild thoracic scoliosis due to a limp, but that is causing intermittent pain despite PT? Okay. So typical recommendations for mild thoracic scoliosis. So definitely, doing physical therapy to balance out those muscles around the apex of the curve, very important. You know, and certainly following on observing, if it's in that bracing range, sometimes we can consider bracing if it's somewhere around 25 to 40 degrees. If it's not, if it's still a little bit more mild, in this kind of 10 to 20, 25 degree range, PT definitely, some is like I talked about earlier, the topical analgesics, heat, massage as well, making sure these kids' book bags are, as light as possible. Sometimes these kids are lugging around, 30, 40-pound book bags on their back, which could, add to some of the discomfort as well, even despite doing PT as well too. All right, next question. My daughter is 14 and has had checks for scoliosis, but I recently took her to the chiropractor after consistent complaints of lower back pain. There. And the bottom half of her back is clearly curved. Is it possible not to have scoliosis, but still have curvature of your back that causes pain? And that's absolutely correct. So we have big muscles that go from our butt up to our neck called our paraspinal muscles, and they give us our posture, give us our support. And sometimes these muscles on either side of the spine can become imbalanced. And if one side is a little stronger than the other, it could clinically make the child look like they have asymmetry to their back and make them look like they have scoliosis, but they come to see us and we get x-rays and their spine is perfectly straight. So sometimes this muscle imbalance that's causing the pain can also cause it to look like they have scoliosis. And so, yes, it is possible to have the looks of scoliosis purely driven from muscle and muscle imbalance, but not actually that greater than 10-degree curve in the spine. The question, does brachial plexus injury at birth increase your chance of getting scoliosis later in life due to one side of your body always dropping down? And I would say no. You know, that wouldn't cause a scoliosis per se in terms of an idiopathic, or does it cause the spine to deform? Now, if you're constantly drooping down one side, that's going to cause an apparent curvature, apparent scoliosis, but it's not going to cause your spine to stay that way throughout life. And it's something to look, if you do have a brachial plexus injury and have a curve, is there at the time of the brachial plexus injury something else that happened neurologically in the spine that was causing the scoliosis too? But if it was just an isolated brachial plexus injury, we don't see that increasing the chances of having scoliosis. Another question. We started with the Rego brace and saw 14 degrees correction. Now with the generic brace, we are seeing regression. Any advice? So that's tough, and that's kind of disheartening on the kids and the parents. So a Rego brace is a type of a full-time scoliosis brace that is a little bit more form-fitting and tries to put in some rotation along with just left and right pushing of the spine. And People do have good results with the Rego braces. Uh, you know, if we're with a generic brace, the design of the brace can be a little different. If it's not as kind of form-fitting, you're pushing as much as the Rego brace. Yeah, I would say if you're getting a good correction with the Rego, sticking with it. We do have orthotists here in Charlotte that do make Rego type braces. And I think if you've had success and you see yourself falling off with a different generic brace or different type of scoliosis brace, going back to what works would be my recommendation. Another question. We discovered my daughter has scoliosis from an MRI. Never knew this. She's 15. She has lower back pain often now, especially during volleyball. Is this pain related to her scoliosis? So very similar to the other question. Uh, So I'm not sure they may even be teammates or the same question, but can it be related to the scoliosis? It can be related to the scoliosis, but if the curve is a little bit higher and the pain is lower, a lot of times it's not. It can be related to her volleyball, other activities. Most of the time, whether it is related to scoliosis or back pain in adolescents, which we do see very frequently in our office here, it's muscular. Greater than 80% of the time, it's due to muscle imbalance, core imbalance as these kids are going and growing through puberty and being very active with the sports that are now year-round sports. So, making sure she's getting checked and following her scoliosis, make sure it's not progressing. That can be causing the pain of the scoliosis, but also working on the muscles, PT, stretching, keeping flexible. The other modalities as well can help with that back pain. Right. What is the maximum time for healing of the lumbar spine scoliosis after surgery? Surgery more than 2 years ago, and I'm still sore. So, good question. Studies show that the body heals even 2+ years after surgery. So, even though the surgery is done, the body still adjusts to the straighter spine even 2 years after surgery. So, having some soreness as your body is still adjusting is not uncommon. And it should be it should be less than what you've had maybe a year ago, and certainly less than when surgery happened. There may still be some residual pain with surgery. Really, the ultimate goal of surgery is to stop the curves from getting bigger and to help with the spinal deformity. It doesn't always take away 100% of the pain. But now, if your pain is going up and up and up, and even more than after surgery or before surgery, that may be a reason to have checked out again to make sure everything is okay with implants and make sure everything is okay on the inside there, that no other workup needs to be done. Another question. My 17-year-old son was just told at his well child visit that he has mild scoliosis. Should I take him to an orthopedic doctor for a consult or not worry because it is mild and he won't be growing much more? So, great question. 17-year-old boys typically grow till they're about 16, 17. So, probably pretty close to being done. Now, mild is very subjective. Mild to a pediatrician may be moderate to an orthopedic surgeon or severe. The best thing to do would be at least get a check, get an x-ray to actually put a number to what that scoliosis is. Because if it is 30 degrees, 40 degrees or less, then we know prognosis is very good. And sometimes kids could hide the amount of curve that they have where they may look very mild on the inside or on the outside, but on the inside, these curves could be bigger. So my recommendation would be get an x-ray, see what the actual degree is, and that'll help guide prognosis. And if it truly is mild and he doesn't have much more growing, don't need to worry. My daughter has an S curve that has 47-degree curve on top and 41 on the bottom. She is almost done growing and is very crooked. We had PT in addition to her night brace and are worried about tightness in her muscles. What can we do to be proactive about issues as she grows into an adult? Uh, I think you're doing the things that you should be doing. She's certainly in that surgical range, so that something to consider if she does have a lot of imbalance of shift, trunk shift one way or the other. Then once we start getting to 45, 47 degrees, talking to one of us, is surgery an option? Would that be better if we say, we're just going to kind of keep an eye on things and watch as she gets older? Best things you could do is stay active, keep your flexibility up, PT, core strength, keep your weight down, keep in shape. And those are the best things that could preserve the health of your spine. Even if you say, hey, I'm going to go a non-operative route, we're going to kind of work with this. So keeping that back nice and strong, keeping your weight down is the best thing you could do. Stay active. A question. I have scoliosis and have two metal rods. I feel that scoliosis has returned. I had the two rods placed in October 1998. So, depending upon how long those rods are, how much of your spine was fused, a lot of times we don't fuse the whole spine now. We just fuse where that curve is. Now, back in the olden days, if you will, we would put in big straight rods that went from stem to stern, top of the neck all the way down almost to the butt. Didn't matter where your curve was. Implants technology made that better where we use less material and get better correction, but that means it leaves some vertebra open or vertebra that weren't touched, that sometimes scoliosis above or below where it was worked can progress or can come back. So if it's been that long and you feel like there's been a shift, then I'd say once again getting some X-rays and seeing if everything is okay, both with the instrumented area, the area that was worked on with surgery in 1998, as well as the area that wasn't worked on, and see if scoliosis truly has progressed. And if it has, then there's things that we can do and we can offer, surgical and non-surgical, to help out with that. And I'd say if you have had surgery, getting x-rays every about 2 years or so, 2 to 3 years, just for kind of routine radiographic maintenance follow-up would be a great idea. Another question. If a 13-year-old boy has fusion surgery, would you expect additional surgeries needed in his 40s, 50s due to degradation of the surrounding unfused vertebra? So another great question. So that's what we follow in terms of research and are looking kind of long term and seeing, what is the risks of people needing something else. And as of right now, the long term prognosis of needing something else is pretty low. It's not zero, and also kind of depends other factors. Depends upon how much was fused to begin with, how many unfused vertebrae are left. If he's got a lot of unfused vertebrae left, he had a smaller fusion, he probably wouldn't need anything. May never need anything else. If he has a larger fusion and he puts a lot of miles on his back, there's a chance. There's probably a good 25% or more chance that he may need something else on his back, whether it's additional fusion, or if the vertebrae that are unfused start to wear out, then may need something else as he gets older. So the distinct percentage is tough to say, but yeah, it would be based off of how much work was done at the beginning, and then also kind of taking care of the back and monitoring, following up. Said getting X-rays every 2 to 3 years, following as he does get older, and seeing kind of what the nature of his back is. But I would hope that 13-year-old having surgery now, hopefully never needs another procedure. But if they do, typically it wouldn't be until a little bit later on in life. All right. So we're coming to about 5:30 here. I want to thank you all for attending OrthoCarolina's live webinar for December. This recording will be posted on our social channels, Facebook, Instagram, YouTube accounts. Thank you and have a great night. Happy holidays.